Good morning. My name's Suzanne Atkinson. I'm a physician in Pittsburgh, Pennsylvania. I'll be speaking to you later this afternoon on some emergency medicine topics, but I wanted to take 30 seconds and introduce our first speaker, Dr. Jim Withers. I'm honored to introduce him. Jim has been my mentor and good friend for more time than I'd like to admit to right now. I met Jim long before I ever considered going to medical school, and Jim is the founder of Operation Safety Net in Pittsburgh, Pennsylvania, and over the years he's made quite a number of friends amongst physicians, nurses, social workers around the country and around the world doing similar things, and about 5-6 years ago he founded the International Street Medicine Institute. And we're pleased to be here with you today, introducing some of the things that we've learned, and hopefully you guys can take from that. So I'd like to introduce Jim. If you're interested in the details, there's a more formal introduction with dates and names and places in your packet about Jim.
Thanks, Suzanne.
You're welcome.
It's great to be here. Thanks for coming today. And we have assembled a team here to try to give you the basics, the nuts and bolts, if you will, of working with people on the streets. We call this street medicine. It's the bringing of medical care, way more than just medical care, of course. Once you get involved with street people, you realize that. But fundamentally, bringing health care directly to people that are sleeping under bridges, in abandoned buildings, along riverbanks, in non-traditional places of living. So it's a movement, if you will. In the last 10, 20 years, it's been gaining a lot of momentum. But I think as long as there have been people that are excluded or don't fit into society, you know, there have been folks out there who the rest of society hasn't really understood or known how to interface with. So street medicine, as I said, is our topic. And if we can get the lights down a little, that would help.
I think it's working okay.
Okay.
At least turn them back on when we get to Dr. Withers again.
All right. Sorry. So I'm going to make this a little personal because I think that's the way we work. We work with the stories of individuals. Each person's story actually really matters to us. The gentleman here, this is my dad, passed away unfortunately a couple years ago, but he was a family doctor, a country doctor, and I made house calls with him as a kid. And then as a family, we worked in Central America. This is in the highlands of Guatemala, and that's my mom with the blue jeans shirt on. And that's me on the right side here with my funky shorts. Off doing medical work in Central America. And then later on, of course, I got the travel bug, and I'm sure some of you have done your own traveling, but it's a very rewarding thing to deliver medical care far away in someone else's world on their terms, which I think is one of the fundamental principles of what street medicine is also about. When I settled in Pittsburgh, Pennsylvania, for my medical school and career, it was the first time I had really lived in an urban environment. Pittsburgh has a lot of bridges, and later on I realized there's a lot of people living under a lot of those bridges. And my place of employment for most of my career has been at Mercy Hospital, which is right downtown Pittsburgh, which has a mission to the poor. Street people I chose when I became a medical educator because as I worked with various issues, domestic violence and some other issues that I was very interested in, this whole theme of being in someone else's reality, or else just being able to get close to someone else's reality was very important. It was the house calls I made with my dad. It was going overseas and being in someone else's country, their world, understanding the context of their health care. When I worked in domestic violence, it was this usually woman is in a situation that nobody is seeing or acknowledging. Is there a way for us as healers, as healthcare people, to go to that world, honor it, understand it, respect the strengths of that person, and then partner with them for a healthier future? That's a skill that it's sorely needed in medical training. I don't think we get any formal training on how to how to get into someone else's shoes, how to be in their world. So I tried to go overseas again with my residents and students, and that really didn't work out very well at my hospital. It was all, okay, you can take your own vacation time, you can do that on your own time, but it wasn't going to be part of the mainstream education. So I began to look locally for a classroom, if you will, a classroom in which I would be forced and my students would be forced to work on someone else's terms, to be in their world. And it occurred to me that street people were pretty awesome as far as that was concerned. There were three things that I wanted in this classroom. The first was I needed folks that were conveniently located, local to my teaching career. Two, I wanted people that were excluded, that were alienated, that were clearly not part of adequate health care for whatever reason. And third, I wanted people that were really ornery, people that were really stubborn and not willing, for whatever reason, to come to me on my terms. But I would be forced to go to them on their terms. So back in '92, I began to work in various soup kitchens and shelters, but that still wasn't what I wanted. I wanted to get out to the people that wouldn't even come to those clinics that were located in those locations. And so I met a guy who had been homeless himself, Mike Salos. He was homeless for 7 years. And he was going out under bridges, and he was putting blankets on people and giving them food. And I said, I'm a physician. I would like to come out with you under the bridges. And he looked skeptically at me, and he says, well, you know, they don't like doctors. And I said, yeah, I kind of got that. And I want to understand that. He said, okay, you can come out on two conditions. One, you don't dress like a doctor. Two, you don't act like an asshole. Those were Mike's two conditions. And so my way of not dressing like a doctor was I got a book called 52 Ways to Help the Homeless. And in one of the chapters it said, if you want to actually get to know homeless people, you should dress like a homeless person. And it has a little recipe for dirt you can put in your hair and how to put on these skanky clothes. And so I did all this, and I showed up, and Mike looks at me and he says, okay, you got the look. But then he proceeded to road test me, really. And Suzanne understands what that means when Mike road tests you. But so a whole new world opened up to me, and pretty soon I was going out 2, even 3 nights a week. The reason we picked the nights was because we knew who was actually sleeping outside, and that's what I wanted to work with, those folks. And it was a whole new world, and it became a very inconvenient experience for me because I would go home at night, and it would be cold rain, and I would actually have knowledge of human beings, individuals that actually were people that I was really beginning to care about. And I was aware now that they were freezing, or that their legs were infected, or they were thinking of killing themselves. You know, these kinds of things were really inconvenient because it really tugs at your heart. And that only firmed my resolve to keep doing this no matter what I was up against. And I think anybody who gets involved with street work, you either turn away and run away from it, or you just can't let go because it's so compelling. This picture is just kind of symbolic of a lot of things. Obviously, there's healthcare issues. The number one cause of loss of your housing in this country recently was cited as health issues, resulting in the loss of jobs, then resulting in loss of income, and then using up all your family supports and your savings and everything else. And then you become one of them because nobody wants to see you anymore because and if you have any weaknesses at all, any addictions, any depression, any self-hatred that is latent, it'll come out. There's a lot of other reasons why people get to the streets, but health becomes an issue the longer you're on streets as well. So this person is exhausted. You know, street people never get a good rest. They're living in a frightening environment. If you want to read an interesting book by Jack London, the author of White Fang and all, he went out and dressed and lived as a street person in 1905 in London for like 6 months. It's a fascinating book, and it unfortunately just shows that things really haven't changed in terms of how society looks at street people. The pigeons in the back here are kind of interesting because the more I work with street people, the more people began to kind of look at me as part of the problem. If you help those people, you're just feeding into that issue. And I think people look at street people a lot of times like the pigeons. If you feed them, they'll keep coming, which is really primitive thinking, but that's how people think. So these are just images of some of the Pittsburgh street people. It gets pretty darn cold in the winter. As I'm sure you've seen your share of street folks, just people making do with whatever they can, mobile. This is what we would call a stage one sort of a street situation, where a person's recently on the streets, doesn't have any kind of street existence yet, doesn't know where to turn. And then people that are on there longer, they begin to settle into camps. And in fact, in the last 10 years, we've seen the emergence of larger and larger camps throughout the United States, where there's a mayor, there's a police force. In Atlanta, they're raising chickens, people specialize. So, the pattern of society in the States is really shifting. And I think as healthcare people, we need to be nimble to be able to go and address those issues wherever they go. And as these guys will point out, even this overlaps even with disaster medicine and other kinds of things like Katrina. This is just lifestyle in the streets. And this was a building in which a little shack that someone built, in which the first year I was out there, a guy died. He'd been on the street for like 30 years. This is Mike, and I have to give Mike credit. He's still the guy that I work with on the street. And I think most communities, in my experience, have a Mike. You may not know who he is or who they are, but there are people that were homeless that do remember what it was like. And that's one of the key ingredients, I think, if you're looking at having a street program, is to understand who are your guides, who are the people that might know the streets and could be your ambassadors to that community. Here we are pretty early on, trespassing. My bag is really small in those days. My ears are prominent, which is, I think, a key factor. You need to listen a lot when you get out there. And then other homeless guys and women emerged. This is Danny. He was one of the leaders in the early times that we're out there, living in one of the shelters downtown. They began to volunteer, and pretty soon we had folks that were giving their own blankets away from the shelter to the people that were still sleeping on the streets. And that was a great inspiration to me and to the folks on the street, to see that someone who had so little would transcend all that and say, what little I've got, I will give to you. And that's the spirit in which we began, and hopefully we continue our work. These are our brothers and sisters on the streets. They're different, but like a brother or sister, you end up caring about them. You don't want to give up on them. You feel like slapping them some days. It's okay, because you're now connected. This is Carol, our first nurse. She would follow me around the hospital saying, I know what you're doing. I want to do that too. And until I said, okay, you can come with us. And then what we did was we began pairing a medical volunteer with a homeless person, a formerly homeless person. And that was our team, a homeless person and a medical person working together. I love this picture because Sister Cindy's a nun and a nurse, and she should have a little halo there. And Danny was a pagan motorcycle gang member and a bank robber, and yet you can see that the love for what the people that they serve and what they're doing is so obvious on their faces. We were beginning to put aside who we were in this work, and I think that's the beginning of rebuilding community. It was when you could set aside your labels and your titles and things and just be human beings. So then we would put teams in different parts of the city so that they would get to intimately know the street population in those parts of the town, like beat cops, if you will. This is just a picture I love because this image keeps coming back over and over in my street career of someone down in a position of respect, listening and trying to get in tune with the person that they're trying to connect with. It's a sign of, to me, it's a visual of respect. But street work had no there was no books on it. There's still not really a textbook on street medicine. So it was all stuff that we were kind of creating, making up as we went along. And but it made sense. Whatever you saw, it was pretty obvious that you'd have to deal with it. There were wounds out there. There were people with infections and issues. This is just one example I like to cite for hospital administrators. This guy had frostbite, and he'd lost the toes. He had a transmetatarsal amputation, and so he was getting, because he wasn't real responsible, he was getting a bone infection. So he had osteomyelitis, admitted for 6 weeks of IV antibiotics. You can imagine what that is per day, $1,200, $1,500, whatever it is nowadays, for 6 weeks. And they would release him after he had healed up, and then he'd get reinfected and he'd come back. So how crazy is that, just in terms of cost? So we decided that guys like him and pregnant women and other people at high risk, we began to stratify and really, really get on them. So we began to focus our case management intensely. We got this guy's wounds to not get reinfected, to heal up completely, and we saved our hospital systems hundreds of thousands of dollars, which they didn't actually thank us for, but you know, that's okay. The symbolism of going to the people, if you will, going there medically, the house call, is really profound. And it sends a message. For me, it was an intentional message for my own profession, that this is what we need to do. But for the street folks, I was really amazed at how they would break down crying. They would say, I cannot believe someone cares that we're still alive. And so, you know, that, I think, as healthcare people, we have a great privilege to be able to enter into people's lives, regardless of who they are. But we also have a lot of moral responsibility to do so, to say that, you know, everybody matters. And symbolically, I think that's what we built this whole health industry on, is that we care enough. This is a scene of trust, transfer of trust. The guy here knows me and trusts me. He's got some mental health issues. He needs to know the guy with the beard, Chris, who's a psychiatric nurse, but he doesn't know him. So I'm personally introducing him to Chris. So if you will, if you look at that hand, it's almost like a graft of one relationship to the next. And these are the principles that the street begins to teach you very quickly. You can't assume that just sending someone somewhere is going to work. You have to actually make sure that the next connection happens. So the street teaches you, if you listen, the street teaches you what you need to know to do that kind of work. And honestly, it has been incredibly exciting to just be able to discover these principles and create a methodology that works for people that otherwise the general healthcare industry is not capable. It doesn't seem to really come up with a good solution. Here I'm getting in trouble because what I'm doing is I'm writing a note to this guy that's under a bridge, and I know him, and I ended up calling his doctor to take care of his blood pressure and his diabetes, and I'm saying he's not there that night, so I'm writing, Dear Frank, your doctor says he'll see you next Thursday at 2 o'clock. So what I'm doing is I'm becoming a home care service for the streets. And so we're beginning to connect, because we are now the ambassadors, if you will, of the street folks who now say, yeah, I do want to get this taken care of. We become the ambassadors into the system. And I'll talk about this later. I call that in-reach, where you're going with people into the system to try to rebuild or create the connections that people need to achieve a healthier life. This quickly turned into a 24/7 on-call service. So we have a toll-free number. It took me 10 years to think of making a toll-free number. I gave quarters out for 10 years, which is crazy. But we have a toll-free number so that any street person can call at 2 o'clock in the morning and say, I don't feel good. I've got this wrong. We don't get as many calls as I'd actually like. I'd rather know what's going on. Any emergency room in Pittsburgh can call us and say, we've got this guy, his name's Bobby, he won't tell us his last name, he's got a tattoo of a fish. Oh, okay, I know him. He's got some mild frostbite, but we're worried that he doesn't understand the instructions. Can you see him? And we'll say, yeah, we'll see him tonight or tomorrow night. He's on the north side under the 9th Street bridge, and we'll make sure that he understands the directions and he gets his meds. So that kind of comprehensive 24/7 coverage for street people makes a lot of sense. And at the time that I started doing this, I was not aware of any 24/7 service for street people like that. Our mission is that as long as, I used to be real dramatic about this, as long as our brothers and sisters are sleeping on the streets, we will go and we will see them. The health care that we provide also must be tailored to meet their reality. The type of medicine that street medicine represents for me is an area I call reality-based health care. It, again, is connecting with the reality of an individual, be they someone in an abusive situation, someone who has circumstances that the system is not capable of dealing with. It's concierge medicine, really, for individuals. It's person-centered care. It's a medical home. It's all those things people are beginning to talk about. But as a place to learn how to deliver care, if you value the individual, you will make it work. And that's what we try to do. We try to do reality-based health care. This is downtown Pittsburgh. We actually extend a bit further than this, but this is just some of the Google thumbnail type things, thumbtacks of where people sleep. My backpack is gotten too big. This is not the one that we'll talk about later. But basically it's Ziploc bags so that when it rains they won't get ruined. And there's a breakdown of different types of supplies that you're going to need. It's good. You have to keep records if you're doing this work. If you have a system that can adapt to it, that's great. We didn't have anything, so we created our own database back in '92, computerized records, so that we could access people on the basis of aliases, tattoos, nicknames, those kinds of physical descriptors that helped us do our logistics of street work, but also then allowed us to keep records. And then having it mobile and web-based, you can be under a bridge and you can check and see what's the latest. And now at this point with our program, you can say, did you know you have a housing appointment tomorrow? And they say, no, nobody got a hold of me. So, this really helps us, again, make the technology serve the reality of the street person. The streets also divide themselves into two basic groups. And this is what I learned just driving downtown to do my work, was that people would learn the color of my car and they would be ready to swarm me when I got out of the car. We would start then with a little open air clinic. And so there's the type of people that come, and they're heterogeneous. All street folks are a very heterogeneous group. There's some themes under there we can talk about later, but folks that come to you, they might want to hustle you for something. They might want to talk about their thoughts of suicide. There are all kinds of things that people need more attention about. And so we did have this open air clinic, and then finally we got a bread truck, and we just said, okay, now we're going to, instead of McDonald's bathroom, we're going to use this bread truck for exams. And then it became this big home. So we have a division of our volunteer pool, if you will, that works in the van, and it's parked at a particular place, and that's a good method. For me, that's one step back from what I like to do, but it frees me and the folks with ADD, that do the walking. Mike calls them hunter-gatherers. He's very connected with his Native American roots. But so here, Mike and one of the nurses is getting sandwiches that the nuns make. We call them nun burgers, to carry out to the people that you have to hunt for. You have to go and find. So it's good to branch into those two basic divisions in terms of street coverage. But we go anywhere. This is, there are a lot of rivers in Pittsburgh, so in the summer the camps kind of get active, and sometimes it's better to actually use kayaks to approach some of those. These are some medical pictures. These are more for cold weather climates. But you see high blood pressure, you see diabetes, you see all the things that you'd normally see just not treated very well. We've seen cervical cancers that are very advanced because women, they don't get checked. You see things that are just ought to have been taken care of, or they were overlooked. And and I'll show you later, they've just been in the emergency room and someone didn't notice the tumor, or the knife sticking out. Stuff like that. They just don't look at street people. And a lot of times the street folks are not their own best advocates. They're using foul language or whatever, and they don't smell good. This is trench foot. You might get that here. I don't know. It's prolonged cold and wet feet, and this is something you got to jump on. This is frostbite. He lost 1 foot and half of the other. This is actually pretty severe. This guy had a mental health condition. He said, I miscalculated. It was a big snowstorm in March that got him. And these don't look that bad, but they are. This is the same foot a little later. You can see the mummification, so they allow it to kind of declare itself, and then this resulted in a transmetatarsal amputations. So there's a lot of people, but we have not had this for 8 years in Pittsburgh. 1 year we had 7 people, but I'd like to claim credit. It may be the weather, but I think it's actually the fact that we're on top of this and we've prevented this from happening. This is a frostbite again. Someone collapsed into a snowbank. This is I don't know how much heroin. I think you have a lot of heroin out here, right? So you probably see this kind of stuff as well. I gave this talk in Amsterdam, and with all their aggressive needle exchange and all that stuff, I showed these pictures, and they said, Hans, come here, look at this. We used to have this, and they don't have this anymore, which made me feel like, I'm in an underdeveloped country. This is the classic bag man, bag ladies kind of thing, where older paranoid schizophrenics who aren't quite sick enough to be committed, they shuffle around, they're afraid of people chasing them, so they're always sitting in a bus stop or something like that, and the gravity causes their legs to swell, the edema causes breakdown of the skin, and then you got these little uninvited guests, maggots, that come in. And this is a guy we used to call, it was called Grandpa. And the only reason he was seeking medical care is because they wouldn't let him in the soup kitchen anymore. He smelled too bad. It wasn't because he was concerned about his wounds. Working with people like this is a real art form. We have one of the greatest people in the country here, Jennifer, who'll speak later, in terms of working with people on their terms in Santa Barbara. But it's all about trust. If you can't argue your point, which you shouldn't try, but you show people that you care about them, you'll get them. They'll begin to believe that you care, and then when the time comes, you'll be able to have some positive impact on their outcome. This is one example of a huge problem. This poor fellow was accosted by a bunch of young people who threw gasoline on him and lit him on fire. Throughout the nation, street people, because of how we don't value them, they are easy prey to usually groups of males in their late teens, early 20s, who beat them, stab them, murder them, and other people that hurt street folks. And it's not a hate crime, except I think in 3 states now. Maryland was the first. I don't know what the next 2 are. But by and large, this happens. I've seen so much of this over the years. And it's one of the things I think we have to stand up and our voice against. There's a guy in our consult service. Consult service is a really good thing to try to do, is to have a consult service in your own hospitals so that when a street person's admitted, there'll be a specialized group that can see the person and then help calm them down, calm the surgeons down, and then help the discharge planning being reality-based so that they don't just come back again. This guy actually did get off the streets. He fell in a fire. His buddy pulled him out of the fire. And then you'll notice that he also has a black eye. The same guy that pulled him out is the one that punched him. So these are very complicated. This is a guy who had a tumor that was not seen the week before in our hospital. We took him back, got him treatment, and this is a discharge plan you just don't want to see. We have a core staff. These are paid staff. 3 of them were homeless, social workers, nurses, that handle the issues later. But then largely we're volunteer driven. So we have a AmeriCorps worker who coordinates our volunteers. Street folks can walk in not ready for prime time, which is important, and get what they need. And then from there, you get them a cup of coffee and you say, let's work on that appointment or whatever. I mentioned the hospital consults and housing. This is something that didn't develop until after the year 2000 when HUD funds became available. So we've actually housed well over 700 street people in the last 7 years in their own apartments. 80% are still in those apartments. So we've become actually, a large part of our work is now housing, and I make home visits to those people as well. So things emerge. If you can keep this guy housed, you can keep anybody housed. And then students. Students have been part of the effort since the very beginning, and we have over 100 students that work with us every year. Nursing students, medical students, pharmacy students, psych residents, and others. And it's a great classroom. This is sort of our classroom of the streets, and there's a waiting list of students to work with us from all over the world, but mostly the States. Out there doing direct care. This is one of my former students who will be speaking later, Dr. Doohan. And then this is just a picture of Bill. Now, Bill, when I took this picture of Bill, he said, "Don't take my picture." And I said, "How come?" And he said, "Because, Doc, when you take people's pictures, they die." And I thought about it, and I do have a lot of pictures of homeless people that aren't around anymore. And I said, "Oh, come on, I want your picture." So I took his picture, and then he died the next week. And what I realized is that I was making a kind of a clinical, but even more so, I think, a spiritual assessment of the fact that Bill was just giving up. And it really bothered me. I was really angry about the fact that people were dying on the streets and no one was remembering them. So I got a donation of $1,000 that wasn't for anything. It was to me. And I said, "I know what I'll do." So I told Mike, "We're going to buy these plaques, and we're going to put on the plaque, 'We remember.' And then we're going to put the person's name or whatever nickname we knew them by, and then the year that they died." And my plan was that we were going to drill them into the sidewalk wherever the person died, and that they would just accumulate throughout Pittsburgh. And pretty soon people would say, "What the heck are these things?" And then we would begin to talk, which is what you really have to do. But the police pointed out that we couldn't do that, so we ended up going to the mayor and we got a wall. So we actually have a memorial wall for everyone who's died on the streets that we know of since 1992. And then we have a memorial service every December 21st where the homeless come, the volunteers come, and we honor the people that have passed away. We acknowledge that they were part of the community, that these were human beings. And to me, that's, in the biggest sense, we are affirming the fact that we're in this together, that this is a community. And I think as healthcare people, we can be leaders in sending that strong message that we're all in it together. We're part of the same community. I think I'm doing pretty good here. That's the Pittsburgh program, Operation Safety Net, and that's the website for that. But I didn't know of anybody else doing this kind of work, and it was very unnerving to me to be doing something like when I finally told my hospital what I was doing. I went to the CEO because a professor said, "Don't tell your boss; they'll shoot you down. Go to the CEO." So I went to Sister Joanne Marie, and I said, "I'm doing this work," and she said, "Interesting. Do you know how our hospital started?" And I said, "No." She said, "This is the first mercy hospital in the world. It was started in 1847 with seven nuns that came over from Ireland, and they walked the streets, and they took care of the poor." And so I thought, yeah, this is going to work. And so once it was okay with her, it was okay with everybody below her. So that was kind of a good lesson for me on how to apologize later. And then I told my malpractice carrier, and I finally called them up, and I said, "I'm doing this thing." And they said, "Okay, are you doing anything you're not capable of, you're not trained?" And I said, "No, everything I'm doing I've been trained to do. Are you keeping records?" And I said, "Yeah." And then they said, and this is our last discussion, "That's fine, don't worry about it." So we were good to go there as far as my thing. But I didn't have anyone to talk to. So for other reasons, I was in India in '93. And I heard about this doctor in Calcutta, Dr. Jack Prager, who had been working under the bridges on the streets directly with people since 1979. And I thought, I got to go see this guy. So I went to Calcutta, and I actually got a chance to talk to Mother Teresa, and she thought it was pretty cool what we're doing. But then I went on to see Jack, and it was like an epiphany for me, because this guy had been working on the streets directly with the poor, and everything that I had tried to do or was thinking of doing, he had figured out somehow. This is one of his open-air clinics, and later they began calling it street medicine. They have their own little van that breaks down just like ours. But at that time, this is in '93, I decided this is actually a field of medicine. No one's given it a name yet, but it's a real thing, and it is a really important thing. And so I became very dedicated from that point on to find anybody who's interested in this, anywhere I could, and connect so that we could learn together how to do this, because this is social justice. This is something that we need to do wherever we are. And in a way, I think it's a way for us to rediscover who we are and to unite with the principles that we really believe in that make us honor our own profession. So slowly people began coming to Pittsburgh, or I started going there. This is a group just south of us in West Virginia that started a program called the Mushroom Program. It's a street outreach. They probably have at most 24 homeless people in Morgantown, but they take care of them, and they're out there and they do a great job. This is in New York City in the Bronx. This is an awesome nurse in Cleveland, Donna Kelly. This is in Santa Barbara. This is Doctors Without Walls. They're represented here. And here they are as a group. This is in Anchorage, Alaska. This is in San Juan, Puerto Rico. This is in Boston. This is in Columbus. Jack's a very experienced clinician, but they've only 2 years. They've only actually been on this, walking into the camps for about 2 years now. This is in New Orleans, where a doctor who became a doctor because he heard about us is now the doctor who goes into the abandoned buildings and works with people with a group there. This is in Albuquerque. This is in Chicago. This is in Copenhagen. This is in Bangkok. This is in Beijing. This is in Kano, Nigeria. So it's just to give you a sense of the fact that a lot of people are either doing or beginning to do this work, and that I'm appealing to you all to join our tribe, as Mimi says. And, if you're doing this work or want to, we need to work together to improve what we're going to do. I think it can integrate into any city because we fill in the cracks. There's always cracks, but we're very fluid and we can fill in the cracks and work with all the interested parties involved. To pull this together then, I actually got a grant from GlaxoSmithKline, I want to thank them, to host a meeting. And so we had our first international street medicine meeting in Pittsburgh in 2005, and Jack came as the keynote speaker. He's been at every meeting. He was at the one earlier this month in Philadelphia. And then Chaco, Dr. Vargas Vidal, who's really a powerhouse in Central America, very inspirational guy. But I got all these pioneers and leaders together, and each year we have a meeting where we bring the best people that we know in the world together to talk about how they take care of their own street people. It's extremely exciting, and there's a lot of good experience. I always get worried that, like, if the building collapses, we're going to lose the world's street medicine experts. But we try to get out in the field and actually do work. This is in Puerto Rico. We're going into the shooting galleries and crack houses. This is a medical student from Alaska who's working with a Puerto Rican doctor, working in the back of a shooting gallery. So we try to walk the walk, even in our meetings. This is a group in Houston, and if I went through, it would be like the United Nations. And then we have a student day. Just the students that we work with present their material as well, because we all believe that the future is teaching our students that it is normal to take care of people and care about the poor. And they teach us things right back. So this is our network, our Mongol horde, if you will, of affiliated communities. It's growing. It's like bicycling down a snow slope for me sometimes to keep up with all this. And to do so, we recently started the Street Medicine Institute. This is that image that has been haunting me my whole career, that to me shows respect, and it's part of the symbol of our institute. The purpose of the Street Medicine Institute is to help communities that want to start street medicine programs on their terms, just like a street person. You know, whatever fits you, we will try to work with you and make it work. And every community is very different. Stakeholders, the issues, they're different. The second part is to improve our practice, to define and improve street medicine as a best practice. The third is to have our annual meetings, which I think are really important to bring the coals together and heat ourselves up. And then the fourth is we're dedicated to a street medicine educational component. So we do exchange students. We send them to Calcutta, to Alaska, to Puerto Rico, and hopefully as our financial capacity improves, we'll be able to have a lot more of a kind of a university, if you will, a fellowship without walls, where we can kind of share students. That's the vision. I think that every community that has street people should have a street medicine program, just like you have a fire department. It saves everybody money, it helps heal the community's misunderstandings, it gets people care that they need, and it opens the doors to all kinds of recovery and housing and things like that. It's just a really good thing. It's surprising how much opposition there is to it, though, and how little support. So we're going to try to crack those with, statistics and arguments, but we're not going to give up. And then I think every health science school should have a classroom of the streets, because I think there's things that you can learn under a bridge that will carry through for the rest of your career. So that's street medicine. And I think I got like 7 minutes left. And we're going to be talking all day about this, but if you have any immediate questions, go ahead and shoot them at me. Yes?
You work along with psych health people, the police. Are the police involved with any of your operations?
In Pittsburgh, okay, I'm sorry. The question is, do we work with the police? Are the police part of our organization? Police are part of the street scene. They are relevant to the homeless street population. So they, by the laws of in-reach, if you will, they must be included. In Pittsburgh, it's been a kind of a so-so relationship. I've been in other cities where the police are actually they have a component where they actually go out and they give people food and they work on people that are high utilizers and stuff like that. That's really not the culture in Pittsburgh. The cultures move back and forth. We do some trainings with the police. They know our number. They will call us. But unfortunately, a lot of times there's a lot of misunderstanding and sometimes even violence that's probably unwarranted towards the homeless from the police department. But, they've got our 24/7 number as well, and every chance we get, we come up and we introduce ourselves and give our cards. It was an interesting story. When I started off and I was dressed like a homeless person, I was hearing about people being beaten up by the police. And I had this dream where I was tied up behind a grocery store, and two policemen were kicking me. And they pulled my wallet out, and they said, "Oh, he's a doctor. We're going to have to get rid of him because he's going to get us in trouble." And I woke up, and I was like, "Oh my gosh, I got to talk to the police. This is really not a good thing." So I went to the medical resident I was working with, and I said, "How can I talk to the cops? I don't understand. I got it." And she looks at me. She says, "My dad's the lieutenant at number 2." And so it was many things that happen like that when you get into this work. So I put my tie on and I went up to number 2, which is, if any of you are old enough to remember Hill Street Blues, that was the Chicago Police Force, but it was the Hill District of Pittsburgh. So number 2 is the Hill and all the downtown area. So I went up there and Lieutenant Booth lined them up, and I said, I'm here because I want your advice. I know you guys know the streets better than I ever will. I'm from Mercy Hospital, and that's where they go if they get shot, so that's good. And I got this medical thing. Do you ever see anybody out there with medical problems? And of the 10, let's say 10 cops in front of me, 8 of them were like, this is great. Nobody ever cares about what we're doing, and they call us, they want us to arrest people, and nobody, so they were opening up, and it was very therapeutic for them, and so I engaged them, and the other two were like, damn it, because they're the people that in any group, when there's a vacuum, the people with fear step in quickest, and they impose hatred of the other. And so I was undermining them by engaging people in a positive way within their own little squad of cops. And for a while, the cops were calling us, they were holding flashlights for us. But then the new mayor came in, all the old cops were kind of let off, the steroid guys came in, and it kind of changed. But we keep working on that relationship constantly. But it's a really good question. Another question? I think we got time for one more. Okay.
In your model of your core people, that you said you had your core group, and then you have, is it like volunteers who are out in the field then?
Right.
And then your core people, are they doing like case management of these people, like trying to get them into service?
Yeah, kind of clean up. Whatever trouble we get into at night has to be dealt with the next day. The first thing we did was we had a secretary in the Department of Medicine who began getting phone calls, and that wasn't her job. She was getting calls from street people, but she loved it. And then, so I got a grant from the hospital in which I was able, she said, you know what, I'll take a pay cut if you'll hire me as your secretary for street people. So she did. We hired her, and then the rest of the money I invested in 2 of the homeless guys to give them some salary, because it wasn't fair not to. So I invested in information management and the guys that were our key ambassadors to the street. Later we got a much larger grant, which got us an administrator. But what was the question?
Yeah, I was just trying to think of like kind of your model, like how you use it.
Oh yeah,
You bring the
yeah.
people in, and then there's
So they come in, and then we actually have I think we have like 4 social workers now that work on issues. Social workers are the key. But we have 2 nurses, and one of them is a psych nurse who does this really complicated problem solving involving lots of appointments and calls, and the other one is totally under bridges, and she's out there, pulling people out with wounds and things like that, and working with them in the daytime. So that's just the way we did. We stretch a penny until it becomes a copper wire in terms of money. So, volunteers are really good, extend your ability. But volunteers are strange people too, so we can talk about that. I think that's all the time I have, and I'm going to let these guys, yeah. So next I'd like to introduce Neil and Mimi. I can't even pronounce Neil's last name. Dr. J and Dr. Doohan, 2 dear friends of mine. I'm going to talk a little bit about Mimi. Mimi came to me as a student at an AMSA meeting, and she said, "That's what I want to do." And I thought, yeah, okay, it sounds like a good plan. But Mimi followed through medical school, through residency. We stayed in touch, and then she went back to Santa Barbara, and she's the founder and the visionary for a program down there called Doctors Without Walls, which now has over 100 volunteers who are out in the streets of Santa Barbara, working with other agencies, doing what no one else will do for the street people of Santa Barbara. And I'm just too proud for words about her. So they're going to talk about their work of street medicine and how this model actually, when taken to another level, applies to situations of disaster, such as what happened in Haiti. So.